Bismillahirrahmanirrahim. This is Dr. Zunaira Faiz. Today I want to give the lecture on the fetal circulation. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. Allahumma inni as'aluka ilman nafin rizqan tayyiban wa amalan mutaqabbala shifa min kulli da. Normal physiology, fetal circulation. Fetal blood is oxygenated in the placenta and then enter the umbilical veins. One portion of the oxygenated blood enters the liver and then drains into inferior vena cava via the hepatic veins. Another portion enters the ductus venosus. It enters directly into the inferior vena cava. Together with venous return from the lower part of the body, the above-mentioned blood flows into the right atrium. So in this you see the umbilical veins, they carry the blood and then it is entering in the liver. Part of it enters directly into the inferior vena cava. Together with the venous return from the lower part of the body, the above mentioned, that is all the blood, it flows into the right atrium. You can see in this diagram, in this picture, from the placenta, the umbilical vein, they carry the blood and then a part of it is going through the ductus venosus into the inferior vena cava and then right atrium. Here is the superior vena cava. From the right atrium, foramen ovale, and then into the left atrium, and then you can see the left ventricle, and then here is the right ventricle. And in this diagram you can see the blood is carrying down and then in aorta going back to the placenta. This circulation is different from the circulation in the human body because of their some changes. Here the foramen ovale, it is patent, ductus venosus, it is there, and then pulmonary, that is the lungs, are not involved. And here the blood is carried, oxygenated in the umbilical veins, and then deoxygenated blood is carried in the umbilical artery. This is in the normal circulation. In the human regular circulation, what happens? The arteries carry the oxygenated blood and veins carry the deoxygenated blood. So here lies the difference. In the right atrium, 1/3 blood is shunted via foramen ovale to the left atrium, left ventricle and ascending aorta. The remainder of the blood in the right atrium joins the venous return from the upper part of the body and enters the right ventricle and pulmonary artery. A small portion of this blood enters via lungs, only a small portion. The remainder, because of highly pulmonary vascular resistance, crosses the ductus arteriosus to the descending aorta. Transitional, what transitional steps occurs? That are the transition to the neonatal circulation. At birth, the infant's first breath causes an increase in arterial oxygen tension, PO2. This lowers the pulmonary vascular resistance, resulting in increased pulmonary blood flow. The increased pulmonary venous return to the left atrium causes the pressure to rise, which results in functional closure of the foramen ovale. Systemic vascular resistance is increased by the elimination of the low resistance vascular circuit of the placenta at birth. Closure of the ductus arteriosus occurs shortly after birth, functionally as a result of a rise in PO2 and a decrease in circulating prostaglandin E2. Second, anatomically as a result of fibrosis, the neonatal circulation is thus established. The ventricles work in series now. Congenital heart diseases. The cause of congenital heart diseases is usually unknown, but in individual cases, evidence points to a multifactorial etiology, with the insult probably occurring in the first 8 weeks of gestation. So, first 8 weeks of gestation are very much important in organogenesis. Congenital heart disease has been associated with several teratogenic factors, for example, maternal medication, folic acid antagonists, anticonvulsants, that is the drugs used for treatment of the epilepsy, estrogens, maternal infections, that is rubella, cytomegalovirus, and maternal diabetes mellitus. Congenital heart disease may be a component of the several syndrome, for example, Down syndrome, Turner syndrome, Marfan syndrome. As far as the diabetes is concerned, if a woman or couple is planning to conceive, they should visit the gynecologist before she conceives, that is in the pre-pregnancy period. Nowadays, it is the era of the antenatal care, and even I more emphasize on this pre-pregnancy care, because this is the time where the diabetes should be controlled. She should have a strict control on the diabetes before she plans to conceive. Incidence. Congenital heart disease affects 8 into 1,000 births. 30% of the infants with the heart lesions also have extracardiac malformations. Classifications. Congenital heart diseases may be cyanotic or acyanotic, may be associated with the cyanosis and may not be associated with the cyanosis of the infant, fetus. Most common are cyanotic heart disease, tetralogy of Fallot, that is TOF, transposition of great vessels, TGA, tricuspid or pulmonary atresia. Atresia means it is totally clear, it is fibrosed, human is fibrosed. So it is a common, we should not ignore, we should not neglect this part also. Cyanotic heart diseases, again, truncus arteriosus, Epstein anomaly, total anomalous pulmonary venous drainage. Acyanotic heart diseases, ventricular septal defects, that is VSD, patent ductus arteriosus, PDA, atrial septal defect, ASD, pulmonary or aortic stenosis, coarctation of aorta. With this, I just finished this lecture, but I will emphasize that during pregnancy, especially early 3 months, women should avoid taking any irrelevant medicines. She should consult her gynecologist for any problem, any sickness, even if she has sore throat, rhinorrhea, even she thinks that she is having fever, it is a simple thing. No, she should consult to her gynecologist before taking any medicines, because we don't know which medicine is more teratogenic and it can affect the cardiovascular system. With this, thank you very much.